just want to start by thanking everyone involved in putting this conference on. It really has been some great talks and a great meeting as well. It's been a pleasure meeting everyone. So I'm going to talk today about some of the serum and urine biomarkers in prostate cancer and really just how do they integrate with kind of in this in the world of MRI that pretty much everyone's getting. So to begin, just looking at kind of the evolution of prostate cancer detection, really in 1986 began, PSA was approved for treatment response and recurrence, and then slowly 1994 gained traction for use in detection and aiding diagnosis. And then flash forward not too long ago, in 2017, this was the AUA statement that there was insufficient evidence to recommend MRI for screening, staging, or surveillance of prostate cancer. 2 years later, in the 2019 EAU guidelines, they had now included to recommend MRI before biopsy for both biopsy naive as well as negative biopsy patients. And then reflecting this, the 2020 update supported the recommendation of MRI before biopsy, which leads us to 2023 and kind of the bulk of the talk is there any real room for biomarkers in this paradigm? And kind of, you can see the guideline here reflecting that, but the focus of this talk isn't really going to go over kind of the data supporting MRI. I think it's pretty well versed, but really, I mean, the bottom line is that MRI has been shown to be predictive of detecting clinically significant cancer, and so as the guidelines reflect, that's where we are. And so we'll talk about biomarkers, in which I'm sure you all know there's plenty of commercially available biomarkers, both serum, urine. There's also tissue-based, which I think is the next talk, but I'm just going to talk about a couple of them and then how they relate to MRI. And so as for biomarkers in the guidelines, you can see here is two distinct pathways between the biomarker or use of an MRI. And really the language is pretty kind of broad. It's basically saying if you think it would influence a decision, you could consider a biopsy or a biomarker if it'll change your decision to biopsy. And similar to the negative biopsy, biomarker testing should not be used effectively, reflexively after a negative biopsy, but maybe used for further risk stratification if it would influence a decision on whether to proceed with another biopsy. So the first test, just quickly go through the 4K. I'm sure most of you are aware of these, but uses 4 kallikreins along with the patient age. And so this is approved for both biopsy naive as well as prior negative biopsy patients. And this is their flow from their website. But this is one of their validation studies. Looked at over 1,000 patients and really was looking at just kind of the threshold cutoffs and kind of to see what would be an appropriate mark. And they found here that kind of if you use the 4K score greater than or equal to 9% cutoff, they avoided 43% of biopsies while missing a small amount of clinically significant cancer. Next is the PHI, or Prostate Health Index, another serum test using PSA, free PSA, and then P2 PSA, which is their proprietary biomarker. It's really just an isoform of free PSA, and so it is FDA approved for both initial and repeat biopsies. Again, kind of the goal of detection and chance of finding cancer on biopsy. And last marker for this talk, SelectMDx, a little different. It's a urine test collected after a modified DRE. And the basis of this is really using these two biomarkers, which are looking at mRNA of this progression gene, DLX1, as well as a cell proliferation gene, HOXC8. And so this is one of the validation studies looking close to 2,000 men, again, looking for the detection of Gleason grade group greater than or equal to 2. And so this was compared to the PCP-TRC, or the risk calculator. And really what they found was using SelectMDx for really all PSAs, not just the cohort that they include of under 10, it outperformed the PCP-TRC. So this kind of leads us to in the age where, I mean, really the guidelines reflected everyone, I feel like, is getting MRIs before biopsies. And so how do the biomarkers really fit into this? And I think it's important to note in all the validation studies, it's really just comparing it for detection. They're not it's really independent of any imaging or targeted biopsies. So I think some of the more important considerations are, one, which patient should have this. There really is kind of a gray area still. The biopsy or the guidelines kind of reflect that as well, but also what the appropriate workflow should be, whether or not you should get it before an MRI or you should get it in conjunction with an MRI, and so we'll talk a little bit about that. So this is a prospective study, 600 patients, and basically developed 4 biopsy strategies. So there's SelectMDx alone, MRI alone. They have this conditional strategy using SelectMDx and if positive, getting an MRI. And then in the last group, both SelectMDx and MRI. And if one of those were positive, then proceed to biopsy. And so there's a lot of information here, but I'll highlight a few things. Kind of as expected, using the conditional, they avoided more biopsies, but you can see here that compared to the MRI, SelectMDx alone had a pretty significant decrease in the amount of biopsies avoided. I think more importantly, though, compared again to MRI, if you were just to use the SelectMDx strategy, you would have missed 10% of clinically significant cancer. And that's reflected here, looking at their DCA. The top line in green has the highest net benefit, and that's just the MRI-only strategy. So it's another study, again, looking at SelectMDx, this time with compared to PSA density for patients that basically looking just at PIRADS 3 lesions. And so you see here that the PSA density alone outperformed the SelectMDx. However, if in combination using both SelectMDx and the PSA density, which I imagine in practice most people are doing or have that information, you see a significant additive benefit by combining them. And again here, I mean, you can see the number of avoided biopsies are the same for SelectMDx and the PSA density, but really, I think key to highlight it here is that it's a small cohort, but they would have missed a third of clinically significant cancer just using the SelectMDx, whereas combining them, they missed 0. So switching, this is talking about PHI and then also PCA3, which we didn't really go over, but another biomarker. And this is looking specifically for previous negative biopsies. So it's a prospective study. Again, MRI's in there. And really, the MRI was the only significant independent predictor of detecting clinically significant cancer for these repeat biopsy cohort. And reflecting this, looking at, this is a 2019 NICE consideration. They were looking at PCA3 and the PHI specifically, and they comment that the committee did not recommend use of these biomarkers. And that's kind of going for overall net benefit, and they do include cost in that recommendation as well. Lastly, this is a study in EAU. It, again, biopsy-naive patients. This is using 4K and then different strategies of timing, using MRI as well as PSA density. And then based on whether or not the previous test was positive or negative, kind of a flow sheet here. And unique to this is they use various 4K thresholds to determine the biopsy. And really, the best biopsy strategy from this was strategy 1 in the blue, which was a 4K score and then getting an MRI if the 4K was over 7.5, and then proceeding to a biopsy if the MRI was positive or the 4K score was greater than 18. And that was followed by the initial MRI with PSA density. And interesting enough, they use 0.1 here. And so you can see here the best strategies, pretty similar oncologic outcomes in terms of detection. However, the initial 4K avoided more biopsies than the second leading strategy. And so there are a lot of other clinical trials kind of out there kind of exploring this option. This one out of Finland, just looking at the different screening tests and seeing efficacy. And really the idea is to hopefully streamline this process and make it an actual kind of a more guideline-driven process of when to use the biomarkers. So again, coming kind of back to the considerations, there really isn't any general consensus on when or if you should use these. I think definitely has some utility, especially if there's a gray area patient. I think makes more sense to me if the MRI is negative and you're kind of on the fence. The other clinical factors are not kind of corresponding to the MRI. Could be just another piece of the puzzle, but I'd be curious to see if anyone else uses this or maybe not at all. Really, it's kind of a cop-out answer, but really at the end of the day, it is kind of, we're in the era of the shared decision-making. And so to conclude, in some of the future directions, really I think someone had talked on this briefly, but if there's a role for using these biomarkers in a different way and quantifying them to compare either like pre or post-treatment or in the active surveillance space, as well as we saw that the different thresholds kind of yielded different results, so standardizing these a little bit better or individualizing them for patients even, and then they could be worked into either risk calculators or nomograms, and then ultimately having a further guideline implementation and really instruction on how to use these. So. Thank you very much.
Okay, we'll introduce the next speaker is Dr. Hao Wen. He'll be talking about tissue-based genomic classifiers for prostate cancer. Can they help identify candidates for active surveillance or focal therapy? And is there impact on outcomes?
Great. Thank you for your time in this last segment of the meeting. So I'm from UCSF, associate professor there. I started 8 years ago. This is my disclosure. I'm a proctoring consultant for EDAP and Inherent Bioscience. So today I'll be going over the role of genomic in the monitoring management of prostate cancer and how it affects the decision in the last 8 years, and then the current guideline outcomes and future directions. So the premise is that when you look at the genetic material of the cancer cell and determine its aggressiveness and predicted behavior, that information may be essential for us to have a more personalized treatment plan for the patient and hopefully improve their outcome and reduce unnecessary treatment. And now we're exploring whether this is suitable to see if the patient is suitable for focal therapy. As you can see on the PROTECT trial, we know that radical treatment do reduce incidence of metastases and local progression. However, that comes with a cost. And can focal therapy flatten this curve, flatten the metastases curve? And if we can use genomic classifier and really identify that dominant tumor and hopefully precisely ablate that, and hopefully that can flatten that curve. And currently, in the last 8 years now, there's a variety of tissue-based genomic marker, and UCSF has been involved in the validation of these 3 commercially available tests. The Oncotype test is a 17 gene signature that's shown to validate the prognosis and prediction for high-grade disease, biochemical recurrent, and metastases. The Polaris test is a 31 cell cycle progression genes and has been validated to predict for recurrent and systematic progression. The Decipher test is the one I use most. It's to help predict for metastasis and death. These are the summary of the current guidelines. So only the NCCN guideline endorsed the use of these genomic classifier, where the AUA or the EAU or ASCO, they said it should not be routinely used, but can be selected, used in cases. So in the last 8 years in our practice at UCSF, we've been using genomic classifier to risk stratify patients to decide whether the patient is suitable for active surveillance or treatment. Now, can we use this to help identify patient for focal therapy? And the answer is maybe. We're still looking at a lot of data. So I'm going to share with you some of the cases how I use this in my practice. So this is a 69-year-old with localized disease, Gleason 3/4, the left mid here. His Polaris risk was low with a 0.5% risk of metastases. So 3/4, so we decided to patient on active surveillance. A confirmatory biopsy a year later still show his disease is stable at 3-4, so we continue active surveillance. 2 years later, we biopsy him again. We see a progression to 4-3 and 3-4 at the left mid. So the Decipher test showed that his Decipher is high risk with an 8% chance of metastases with treatment. So he elected to undergo focal therapy to the left mid and base, his PSA native to 2.1. And on rebiopsy, we found just a focus of Gleason 6 at the left mid, so he's continuing on active surveillance. No change in his sexual function or urinary function. Now, this is another patient. He's 83, healthy, with a localized lesion at the right mid 4-3 cancer. So in this gentleman, he does not want any radical treatment. Obviously, it won't affect his longevity if you treat or don't treat. However, he doesn't want to sit on a 4-3. He's quite healthy, and so we got to Decipher test. So you can see here that his risk of metastasis is 4%. So elected to undergo ablation of the right apex there, and post-HIFU showed that cancer is gone. He still have the cancer on the left side that we gonna do surveillance. So that's how we integrate genomic in these patients. Now, this is a patient, a 60 years old man who has Gleason 3-4 on his left side, entire left side. And CAP4, as you see, he has an unfavorable pathology with the intraductal carcinoma, but he wanted me to do left hemi ablation. So looking at the pathology, I was a little bit concerned about giving him focal therapy. So we decided to get the genomic test, and that shows a high-risk genomic with a 34% of probability of non-organ confined disease. And so we decided against focal therapy. So I took him to surgery, and you can see here this path show a Gleason 4+3+5 with extensive intraductal and extraprostatic extension. So now this is another patient who is 57-year-old, healthy, 3-4 disease, who want me to take his prostate out. So I said, well, you have just one area of cancer here based on the PET scan, based on the MRI. He can consider he would be an ideal candidate for focal therapy, right? But he insists that I'll take his prostate out. So I said, okay, maybe I can get a genomic test. Maybe we can make a decision after that. And this genomic test showed very high risk genomic with a almost 8% risk of metastasis after treatment and 54% chance of an adverse pathology. So we took his prostate out. As you can see, he has extensive intraductal carcinoma that was not seen on that initial biopsy. So that's how this is changing the way we select patient. Now, the question is, we're looking at whether this help us identify multifocal disease in patient who's candidate for active surveillance. So with this, recently, Dr. Kerr and I, we decided to look at our data and look into this question of genomic, whether it can predict focality. So we look at our 3,000 patients who had surgery, and they had the candidate for focal therapy based on locations. And we included only 500 patients who has genomic risk. So either can be done with Decipher test, Oncotype, or the Polaris. So the outcome is candidacy for focal therapy. Definition for focal therapy is organ-confined disease, unilateral or unifocal in a single or continuous sextant, grade 2 to 3 on radical prostatectomy. So on initial biopsies, about 30% of these patients are candidate for focal therapy based on the initial biopsy. And on the genomic risk, 70% of the patient has low risk genomic, and 26% has high risk genomic score. So on the final pathology, 94% has bilateral disease, and 97% were not candidate for focal therapy. only 3% are candidate for focal therapy or hemiablation. So that was surprising. And when we look at whether high-risk genomic score was associated with the likelihood of focality on radical prostatectomy, and that didn't show any association or even having a positive lesion on MRI. So our finding is consistent with other studies highlighting the fact that there's a high degree of multifocality and bilateral disease in men with prostate cancer. High genomic is not associated with multifocal disease. There's limitation, this is a single center study, and high utilization of active surveillance in men who may be treated with focal therapy at the other side. So the question now is, do genomic risk predict for infield recurrence? The answer is unknown, and I think these classifiers are not validated to predict these things, so we shouldn't be using them for these, actually. But we'll find out. So is there any impact on outcome? The answer is unclear. So there's no randomized trial on this, whether to impact or save life when we use genomics. So in summary, we know that the role of tissue-based assay is important for to select men on active surveillance or not. It may have potential uses in select patients who are candidate for focal therapy, still an area of active research. The clinical utility or cost effectiveness has yet to be determined, and is not associated with, it does not appear to be predicting multifocality or MI invisible cancer. And in the future, patients will have a variety of broad ranges of genomic classification at their disposal, so they will use it to make their decision. The physician will use it. And we need to understand the limitation and the strength of these tests. And I think for focal therapy, we need to develop new genomic classifier to predict for focal therapy effectiveness. So I'd like to acknowledge Dr. Carroll, my mentor at UCSF, Dr. Shinohara, and our oncology team.
All right, next up we have Dr. Mark Ball talking about how the genetics of renal cancers impact clinical behavior and treatment decisions.
Thank you very much for allowing me to sneak one more kidney cancer talk into a prostate cancer session. So what I hope to show is that knowledge of kidney cancer genes can guide multiple decision points. It can guide who to operate on, when to operate, meaning when to do active surveillance versus immediate intervention, and how to operate in terms of surgical approach and extent of margin resection. So these are 4 renal masses. These are all patients that we've treated at the NCI. They're all small renal masses, 2 to 2.5 centimeters, all sort of mesophytic to endophytic, abutting the renal sinus. Can genetics change what we do for these 4 patients? And we'll come back to these. And I'll also show just a little bit more of an extreme case. This was a woman we saw about 2 years ago now who was recently diagnosed with COVID and had cross-sectional imaging that demonstrated masses in the kidneys. And here you can see the imaging for this patient, multiple large renal masses in both kidneys. And so when we saw this patient, we asked, can we optimize this patient's therapy by doing an in-depth genetic analysis? And we'll come back to this case. So just to take a step back, we often talk about precision medicine, and when we do, it's often in terms of advanced cancers. Can we tailor genetic alterations found in tumors to systemic therapy? And the Precision Medicine Initiative from the NIH it does just that. It takes into account people's individual variations in genes, environment, and lifestyle. I would argue that we can not only do that for advanced disease, but we can do that for localized disease. And really, when we're using genetic information to tailor surgical approach, we're talking about not just precision medicine, but precision surgery. So what does that mean? Well, this is a slide that I borrowed from my boss and mentor, Marston Linehan, who, with the help of folks like Maria Marino, who is in the audience, who we'll hear from next, have shown us that kidney cancer isn't just one disease. It happens to be multiple diseases that arise in the same organ. Not only are these morphologically different under the microscope, but they behave different clinically. They grow at different rates. They have different metastatic potential. They respond differently to different systemic therapies, and I would argue require tailored surgical approaches to tackle them most efficiently. We know there are at least 12 known syndromes that confer predisposition to kidney cancer, and that in an unselected series, 5 to 8% of patients with a kidney cancer will, with a workup, can be found to have a hereditary kidney cancer syndrome. But we also know that multifocal kidney cancer is common. Upwards of a quarter of cases can have multifocal involvement, either through incipient lesions or multiple tumors in a single kidney, or maybe bilateral disease. So it's likely higher than that 5 to 8%, and we get smarter as we look more. So who and when do we operate on, and how can knowledge of genetics guide us? I think the who and when really comes from an assessment of the biologic potential. And this comes from sort of two data points. One is size and how that relates to metastatic potential. And two is how different genetically defined tumors grow on active surveillance. So we know from the sporadic kidney cancer literature from multiple series that size at presentation correlates with the risk of synchronous metastatic disease. Long-winded way of saying bigger tumors are worse actors in general. But we also know more specifically from patients with hereditary kidney cancer syndromes. When we look at patients treated at the NCI with 3 syndromes, von Hippel-Lindau, Birt-Hogg-Dubé, and hereditary papillary renal carcinoma, that we've not seen a single patient who has developed metastatic disease when their largest tumor has been 3 centimeters or less at the time of treatment. However, for patients with larger tumors, we see that the metastatic potential slowly increases. So by the time you get to 7 centimeters, 60% of VHL patients, 30% of BHD, and 40% of hereditary papillary kidney cancers can have metastatic potential. Let's contrast that very starkly to a different syndrome that we see not infrequently at the NCI, which is hereditary leiomyomatosis and renal cell carcinoma, or HLRCC. These patients are at risk for development of metastatic disease with small tumors. We see with tumors between 1 and 2 centimeters, and actually everything above 1 centimeter, the risk of metastatic disease is around a quarter. And by the time we get to that 7 centimeters that we saw on the last slide, 70% can develop metastatic disease. So very different beast than those other syndromes on the last slide, right? So for that reason, we don't do active surveillance for HLRCC. So we don't know a lot about growth rates, but we do for the others. So this is a study we did a few years ago looking at growth rates, characterizing different genetically defined syndromes, and we see very different rates. For patients with a germline BAP1 alteration, which is which causes clear cell kidney cancer, these are very rapidly growing tumors. VHLs have sort of moderately rapidly growing tumors, while MET activated, which we see in hereditary papillary, and folliculin deficient, which we see in Birt-Hogg-Dubé, have slower growing tumors. And to show that same data in a slightly different way, we can see very nicely distinct growth rates by genetic alterations. So again, the genes here tell us, are these fast growing? Are they something that we need to worry about or not? So I would say, to answer those first 2 questions, who and when, at size, we really don't perform surgery until a tumor gets to the 3 centimeter threshold, in most cases, for patients with VHL, BHD, and HPRC. On the other hand, we recommend immediate surgery for any suspicious solid tumor in HLRCC. Likewise, with growth, we know that growth rates vary among the different histologies, but they're somewhat predictable. So this really informs our active surveillance schedules. We don't surveil patients with Birt-Hogg-Dubé as often as we do with patients with a germline BAP1 alteration. and that's really based solely on their germline genetics. Let's talk about how to operate, and that's really two questions there: approach, open versus minimally invasive, and extent of resection, or how much margin we're taking. So in general, we perform most of our surgeries in a minimally invasive fashion at the NCI, about 90%. But the exception are for patients with HLRCC. And the reason for that is that we have seen patients treated with minimally invasive surgery who have seeding of the retroperitoneum and the peritoneum and have sort of atypical recurrences. These are two different patients, although they look somewhat similar, with large cystic areas with solid parts as well, who had actually minimally invasive radical nephrectomy before presenting to us. For that reason, we are a little bit conservative. We do open surgery for HLRCC. But what about for patients who require multiple surgeries? Well, for those patients, we actually prefer robotic surgery. We think that robotic surgery has a less of a surgical footprint, if you will, less scar tissue internally. And this is a study from one of our fellows who's attending now, Sandeep Guram, showing that we have fewer high-grade complications and less blood loss in cases with a robotic approach, even for patients with 4th, 5th, and 6th time partial nephrectomies. Extent of resection. Oops, going the wrong way here. So for the reasons that I've already explained for HLRCC, we prefer a wide resection because these tumors can seed. We think probably the same for SDH, although those numbers are small. On the other hand, for patients with VHL, HPRC, and BHD, we often perform enucleation. And enucleation is really the original focal therapy approach. This is when we're sparing all the normal parenchyma we can. We get right on the pseudocapsule of the tumor. This kidney, the hilum, is not clamped. So when we're in the right plane, we can get a fully encapsulated tumor with very little bleeding from the kidney, almost no impact on kidney function because we have both zero ischemia and we're not taking out any nephrons. So to answer those two questions, how to operate, it's largely at the surgeon's discretion. We do think that robotics may minimize scarring internally and associated with fewer complications, but we do recommend open for HLRCC. Extent of resection, again, enucleation for VHL and a wide margin for HLRCC. So going back to these four masses, and I'm running out of time, but just to wrap up here. So if I told you now that we know germline genetics for these four masses, it kind of changes how we approach things. For BHD, a 2.5 centimeter tumor, we can do active surveillance, and we can really do this at a 2-year interval. When it's time to operate, we do robotic surgery with enucleation. Let's now look at the last column, HLRCC, a 2 centimeter tumor. We're going to do immediate surgery. We're going to consider open, and if we aren't confident with our margin for a deep tumor like this, we have a low threshold to actually do a radical nephrectomy. Then going back quickly to this case, this patient with the complex renal masses has Birt-Hogg-Dubé. So we know that these can be indolent tumors, and we perform a tumor enucleation on both kidneys, staged partial nephrectomies, 6 tumors on the left, 5 on the right. Had good preservation of the renal function, and these are the postoperative scans. When we do a tight enucleation, we can really spare 90% of the renal parenchyma with almost no impact on the overall kidney function. So in that short time, I hope I can convince you that the knowledge of driver genes can inform growth rates, it can inform metastatic potential, when to operate, active surveillance intervals, surgical approach vis-a-vis open versus minimally invasive, and extent of margins. This is really a team effort at the NCI. We're indebted to our colleagues in pathology, in radiology, in genetics, and in the lab to help us take care of these patients. Thank you very much.
Okay, our next speaker is Dr. Maria Marino, and she'll be talking about the interpreting prostate biopsies after focal therapy.
Good afternoon. And I want to express my gratitude to Dr. Pinto and colleagues for allowing pathologists to share this time with you. My task today is to share a little bit of pathology about what do we find in the cases that have biopsies many times before and after they have undergone some ablative surgery. This is actually a little bit of an old paper, but a very good paper. Remember, these techniques are kind of new relatively. We are very familiar with the changes that you can expect in patients that have been treated with radiation therapy. So to a point, we didn't know exactly what to expect after ablation therapies. The most important thing that we have to do, of course, is to provide a diagnosis for recurrent disease or not. And we divided the prostate after the therapy in those that are treated and they are not treated. In the biopsy, and these are the things that you as urologists need to ask from us, the pathologists, is number one, is the presence or absence of residual tumor. And if this tumor is of the same grade as the primary, and here we come that we had to learn whether there were morphologic changes that could represent just changes of therapy and not of upgrading the tumor. And last, we wanted to know, and we would like to know, this is ongoing studies, if there are any molecular changes that can change after the treatment and that perhaps can lead us to better identify the tumors. This is the paper that I was started to mention to you, and it was very nice because it gave us a little bit of the initial ideas of what we had to do. They studied 45 patients, and then they had a number that had an increase in the PSA on the indicating recurrent disease, and some of them had prostate biopsies. They also did biopsies in patients that did not have an elevation of the PSA, but that they were for evaluation of the disease. For the pathologists, one of the most important findings that they reported was that the cases that there was a large number of patients, approximately 70%, that had recurrence disease or persistent disease in the prostate. And the number of patients with tumor in those that did not have the elevation of the PSA was smaller, more or less about 20%. There have been other studies in there, and I think that the numbers are very stable. Of course, there need to be more studies, but I think that this study does give us a very good indication of what we are going to find. The important thing that they mention for the pathologists is that in none of the cases that they review after the ablation therapy, there were significant morphologic changes that were different from the primary tumor. In other words, this therapy did not affect the tumor as much as the radiation therapy. So that was a good indication for us. And this is what I want to show you today. The most common finding that is always reported is the presence of fibrosis. So in other words, the cores become very eosinophilic, but there are no epithelial cells. You can find, like in the left, the lower corner, that you see some brownish color. Those are macrophages. Probably this is close to an area of biopsy or something else, and it's just healing, it's repairing with chronic inflammation. But this is a very common view of an ablated or HIFU prostatic biopsy. And this is another case. This was performed by Dr. Wood, and the biopsy is by Dr. Pinto. And we were happy. Again, the core doesn't seem to be really as fibrotic as you saw in the prior biopsy. And we see some glands, and the glands actually look very benign. Now, we have two possibilities. Either this is an area where the treatment didn't reach, or it wasn't effective, or this is far away from the treated. So this was benign glands. And as we look a little bit later, a little farther, you can see a cluster in the right upper corner that seem to be having some glands that are kind of crowded, and then the remaining of the tissue is eosinophilic, is very pink. In the lower quadrant, you can see glands. These glands are tumor glands, but these glands look very much like a grade 6 prostatic cancer. In other words, it's a low-grade cancer. And the important thing is we don't see a lot of morphologic changes that can be due to therapy. This is a very interesting question that, as we discussed yesterday, it has importance in the issue of changing the grade 6 prostate cancer to a more benign nomenclature, because we will have to decide what do we do with these patients that undergo ablation therapy. So far, we stick with our grade. This is adenocarcinoma. We can confirm that in a higher power. You can see they are very open glands. These are grade 3 glands, not a question asked. And then you can say, well, how do you know it's cancer? Well, we know it's cancer because when you do immunohistochemistry, these glands are missing the basal cells. So there's no question of what it was. So this patient did have a persistency or a new tumor, Gleason grade 6. And that's how we diagnose them. We do not see, indeed, the significant changes that we see in cases, for example, like radiation therapy. This is for comparison. You can see the same kind of hyalinization of the stroma, but with the prostatic changes, and here you have 2 glands or 3 glands that are very, very atypical. They're very abnormal, and sometimes you see the significant atypia is just the effect, is a benign gland with effect of therapy. But in the upper corner, we did have a gland that did not stain with our basal cell markers, so we knew that there was tumor here. With radiation therapy, it's different because in many cases, we cannot grade them. And we have to say cancer. I usually try to say if it is poorly differentiated or not, but we cannot do that very frequently. With the ablation therapy, I think we are not going to have that problem because since most of the glands remember what the tumor was, we can give quite a good grade. Suffice also to say that most of the cases that we have seen at NIH were low grade, grade 6, and the recurrences of the therapy that we have seen, they are all the same grade, grade 6. The glands were all 3. So that is for the good news. So in conclusion, we can say that the post-HIFU or ablation therapy with all the different types of ablation therapies that are now available are probably positive in a high number of patients, especially those that have rising PSA, and also a good number in those that do not have the elevation of the PSA, but that are obtained for routine. Stromal fibrosis is the most common finding and is probably the result of the therapy. And these therapies are not going to be a terrible problem for the pathologist, and this is something that when you go to review your biopsies with the pathologist, as I'm sure you all do, you can ask clearly, do you see anything, any change in grade? That's the other thing we have not seen, any change in grade. We, with Dr. Pinto, of course, went back to some of the cases that not been treated, but that had been called 3 and then recur, and re-reviewing those biopsies, and with the new criteria for grading prostatic cancer, those did have a grade of 4 focally in some areas. Fortunately, in these cases, we have not found that. And what is very important is what the pathologist always asks from the clinicians: provide the information. Tell us that this patient has had this type of therapy or the other type of therapy, because we can do a lot of other things according to your needs. And our hope is that not in the future, if we are able to obtain a decent number of prostates, that biopsies that also undergo prostatectomy, that we will be able to do more molecular studies. This is, of course, a prostatectomy performed by Dr. Pinto. You can see what an excellent prostatectomy specimen it is. And this is in particular from a very prior report that we did, trying to do the molecular analysis of all the different grades of prostate cancer that you can identify in one prostatectomy. As you know, this is a cancer that has multiple clones, different morphologies, and different grades. And we were able to confirm that indeed each different grade has a different, more complex molecular analysis. So our hope is to be able to study the original biopsies before they go to ablation therapy, do the molecular studies, and then if they go to prostatectomies, or if they have biopsies for recurrence or elevation of the PSA, that we will be able to study those and see if we can identify any markers that will be able to provide a lot more help. And of course, all this work is always a team effort. I have been very privileged to have an outstanding team that, contrary like husbands, they listen sometimes. Thank you very, very much.
Do we have time for Q&A? Because I know there's Q&A scheduled.
We have 6 minutes.
I had a question for Dr. Ball, actually. It was a great talk. Everybody, all talks were great. But how does the, I'm just curious, patients with hereditary syndromes, how do the incidence of metastasis differ from someone who, let's say, with a clear cell that does not have VHL? Is it vastly different, or is it similar?
It's a good question. It's interesting that when we look at sporadic kidney cancer, the literature on the incidence of metastasis, most of it is kind of all comers. And a lot of it is all comers without biopsy. Some haven't gone on to surgery. So to break it down by histology, we don't have great data, which is kind of surprising.
Yeah.
Shouldn't be that hard in some ways. We think it should be pretty similar. 90% plus of sporadic clear cell kidney cancers have either mutations or methylation in VHL, so it's all driven by the same pathway.
Right.
Likewise, in papillary kidney cancer, 80% has methylation or sometimes mutation of the MET gene. So we think they're good models for understanding sporadic kidney cancer at large.
Thanks.
Anyone else? All right, maybe we'll just start the next session a little bit early, because I see people need to catch flights.